Thanks for downloading this episode of the Mental Health Book Club podcast. Our last book was Stand Tall Little Girl by Hope Virgo, which covered the topic of eating disorders, particularly anorexia nervosa. For those of you who are wanting to find out more about eating disorders, please go to episode 33 of the MHBC podcast, which I shall put a link in the show notes. Welcome to the Mental Health Book Club podcast with your hosts, Sydney Timmins and the Secret Psychiatrist. We would like to take this opportunity to let you know that we will be covering a diverse range of mental health topics that may be distressing to some listeners. You can find a full list of the topics being covered in our show notes. Please check the show notes before listening to any of our episodes. Welcome to the Mental Health Book Club podcast with your hosts, Sydney Timmins and the Secret Psychiatrist. Just in case you haven't heard the podcast before, we like to do deep dives into particular conditions that we've read about in our books. This one isn't associated with any of the books that we have read recently, but I thought it was a really important one to have a chat about. And we're going to talk about ADHD, but first, I'm going to hand over to the Secret Psychiatrist so she can just give you a bit of background about herself.
Hi everybody, I'm the Secret Psychiatrist, a bit about me if you don't know, and I'm a psychiatrist currently in London with the NHS, and I have a blog, www.thesecretpsychiatrist.com, and you can also find me on Twitter, Instagram, Facebook, and of course on this podcast.
Yay! I always do that, so...
I love that though. I love being
I just
on this
need
podcast.
to go, yay, because it's fantastic, and for a long time, I was trying to do these on my own, and I don't have all the answers, and I try and do as much research as possible to give you guys the information, but I have found the fountain of all knowledge to do with psychiatry, and that is the Secret Psych. So, we're going to get stuck in to ADHD, and I think this is a pretty important topic, particularly if you have children, but you can have ADHD as an adult, as I understand. That's correct, isn't it?
Yeah.
And I think it's really important that we should talk about this because there's lots of issues, particularly if you're a parent and you have a child that may be suffering with this. There's issues and worries about medication. There's issues and worries about their schooling. So it's such a big thing for us to talk about. So I'm going to pass it straight over to you and you tell us about ADHD.
Thank you. So yeah, you're absolutely right. ADHD, so what that stands for, by the way, is attention deficit hyperactivity disorder. So I've seen this a lot when I worked in CAMHS. CAMHS is child and adolescent mental health, and I've seen very happy cases actually of success, and there's no reason why all cases can't be success with this. And I think more and more people are realising, especially parents, when I speak to them and their child's there, that they've realised, oh, they might have ADHD as well. So it's good to always just be aware. So some of the signs, so I'm going to split it up with signs, treatment causes and things like that, so it's easier to follow this podcast. So you obviously, as it says, you can be hyperactive, inattention, and impulsive in your behaviour. And there's different criterias, but usually it's more than one setting, so 2 settings or more. And it's not due to other causes. So for instance, these signs and symptoms are not due to schizophrenia, for example. And these symptoms have to cause severe impact, sort of impairment out of the norm for that child of their age and in their circumstances. Now, you might find them, if you're trying to see who has ADHD, they sometimes might interrupt you quite a lot. They're really easily distracted. They can't finish their tasks. If you're a teacher and this child is interrupting you and they're not finishing their homework or what they need to do in class and really distracted by lots of other things and other stimuli, then you might be thinking about ADHD, and they really struggle with focusing on something specific for a long time. So usually these kind of things are picked up on, if not at home, then with teachers, because usually you pick it up in children. Not the case always, of course, but usually the teachers are pretty good at picking this kind of thing up. So usually at school, you notice those children with inattention symptoms more, whereas with younger children, preschool children, so maybe the parents pick this up, you pick up more children with the hyperactivity kind of symptoms. And that might just be because as a parent, your child is so hyperactive, it's really difficult to control them. And at school, obviously teachers might pick up the inattention cases better because obviously they're not paying attention to what's happening in the class. And with adolescents and adults, normally people notice that inattention and impulsiveness with people. And that might be obviously because you have more responsibilities as an adult, and if someone's more impulsive and inattentive, then people pick that up a bit more. So when you can pick this up in age, well, you could technically pick it up after 18 months, but usually, not the case with everyone, you usually pick it up before sort of 7 years or between 7 to 12 years. I mean, it's very varied. It depends where it's picked up, and some people don't pick it up actually, because they might just think it's the child and not ADHD. You need to have it for about 6 months at least. Okay. So what are the causes? I mean, there are few sort of theories going around. So one is genetic. So siblings have a 3 times increased risk. So if I have ADHD, my siblings at 3 times increased risk of also having it. And genetically, they're thinking of genes 5, 6, and 11 that are implicated as well. And areas of the brain, they think there's theories of that. So the prefrontal cortex, so that's the front area of the brain basically. And that controls sort of social behaviour, cognitive behaviour, and sort of discrimination and that kind of social kind of behaviour basically. The striatum, which is another area of the brain, so that kind of looks at in sort of voluntary movement, and the cerebellum, so that's sort of the coordination as well. And there's a theory about dopamine transmission dysfunction as well. That all ties in with that as well. Prenatally, so obviously mum with the baby, pregnant, so having exposure to nicotine and alcohol as well can increase your risk. And having a low birth, poor attachment, obstetric complications. So if you're pregnant and you have lots of complications in your pregnancy, that stress and trauma can possibly increase your risk to get ADHD. And there's a sort of theory about head injury. So if you have head injury, there's a 25% risk of having ADHD. And there's been some cases found actually. So it might not just be from birth and genetic, it can happen later in life, obviously from head injury. And another thing I'll just add before I pause is it's more likely in boys, so 3 to 1 boys. And roughly in the Western sort of culture, you find about up to 5% of cases of ADHD. And there's a big political issue, and that's why I said 5% in the Western culture, because there's issues even with psychiatrists, because you tend to find ADHD more in the Western culture rather than developing countries such as India. Different theories as to why, whether it's the social upbringing of families and the parentage, but that's the percentage we have basically. Before I carry on, is there any questions or surprises or kind of what you expected?
Not necessarily, yeah, for ADHD, particularly with like some of the things that Becky says, because obviously she's a school teacher and she deals with teenagers that may be impacted by ADHD. Yeah. And she's also very much more in the pastoral role. So she is the one that's there looking out for the students' welfare and behavioural issues. So this one, I think she's going to find extremely interesting. And I've also got her list of questions that she would like to ask for you as well. So you're going to have a few, I'm afraid. Good. But yeah, no, that sounds kind of what I was expecting, I think.
So I'll answer something you mentioned earlier, right at the beginning of the podcast. So 15% continue into adulthood with ADHD. So quite a high number, actually. And 50% suffer residual symptoms as well. So it can really impact people, and you can have it lifelong as well if you're not able to maintain it. And I mean, I always say there's no cure for everything in life, but if you're able to get the help and treatment earlier on, you can have really positive, good outcome. Just talking about sort of other outcomes. So 20% develop substance misuse problems if you've had ADHD. And there's a poor prognosis if you've had a quite severe stressful life, such as poverty, overcrowding, difficulties with expressed emotions, prenatal psychopathology. If you have hyperactive, impulsive symptoms, you're more likely to get conduct issues. And also if you've had language and learning disability as well, that can give you a poorer prognosis. And 50 to 80% of ADHD have a comorbid disorder. So what that means is you have another disorder as well. Wow. So yeah, quite a big number. So conduct disorder, if you have it with it, is about 14%, tics 11%, mood disorder 6%, anxiety 34%, and oppositional defiant disorder 40%. So really, really quite big actually. So you can go with other bits as well. How you diagnose it, obviously you would speak to a psychiatrist, and there's different questionnaires. So at school they sometimes use what we call Connor's questionnaire, which Becky probably will know about quite a lot because like being a teacher.
More than likely.
Yeah. So that can help pick up if you've got ADHD. Treatment, it's very multimodal and it's long term. So you look at education, helping the child at school, you know, in the classroom, if they need extra classes or support there. There's parent training programs as well, which are excellent. So it really helps the parent outside school as well to really help the child and educate them as well and do certain behaviours that really help them. There's child management skills as well. There's behavioural skills, interventions, CBT. I mean, CBT is great for everything, really.
Yeah.
There's social skills and all different classes like that. And obviously, if it comes to the line where you can't control it in these ways, and usually you can because they're so effective, these different programs and management skills. But if you have to, then you'll come see the psychiatrist, you'll come see me, and we'll talk about medication. So medication, I always say with anything, mental health is always last resort. If we have to, we will. Obviously, we don't want you to have medication, especially a child. We're very careful and, you know, it's very individual basis because we don't want children to be on medication. So the ones that we would be thinking about are stimulants. And the reason is it will release noradrenaline, dopamine, serotonin, and increases extracellular dopamine. So therefore, essentially, it inhibits like impulses, which can help with ADHD management. But with medication, you've got to be careful in children because obviously they're still growing up and you've got to make sure of their height and weight and take their blood pressure and heart rate and just make sure everything's going okay. And I just want to mention, if you have a medication called atoxamastine, then you've got to monitor signs for depression and suicide because it's very rare, but there is a slight risk of a child getting suicidal ideation or depression with that medication.
Oh, blimey.
And other medications, you can think about antidepressants and antipsychotics. Yes, it's not given lightly and you'll be monitored thoroughly with the CAMS department as well. So, I mean, that was a bit of a whistle-blow tour. I went quite quickly with ADHD, but yeah, I mean, do you want to ask me the questions?
Yeah, are you ready for this? Just going to say,
gosh, I probably won't
are you ready for this?
Yeah.
So, the first one that I've got is there any kind of link between hormonal changes and any impacts upon ADHD, if that makes sense? So, obviously, Becky is dealing with teenagers and then you add in hormones on top of that. Is there any research that shows that there's any impacts?
Yeah.
we're just intrigued.
I'll be completely honest with you. There's still so much research to be done here.
Is there?
And there's still so many theories. And unfortunately, it's not a clear-cut answer. And I know that's not an answer you'd want. But yeah.
It never is. No,
I mean, certain hormones do increase your risk of impulses and aggression and ADHD hyperactivity as well. And I mean, it's not clear cut and there's been no definitive yes or no, if that makes sense.
No, but there is a possibility that it could kind of
I don't
enhance symptoms, as it were, and it might make it a bit more tricky for the teenager at that point when the hormones are changing. Yeah, no, that makes sense.
Yeah.
And the next one, do boys and girls present differently with ADHD? Because I know that in autism
they can.
Yeah. And what are the main differences that you see between boys and girls? I'll
be completely honest, people expect boys more to have it, and that's what the issue is. So people look out for boys more than girls, and it's like with autism. So girls have that. I think that's a really good next podcast to do actually about autism. So boys and girls do have symptoms, but sometimes girls, and this happens with autism, are better at hiding it.
Yeah.
Because they're around, a social group that get excitable about something specific. I don't know. So like with autism, so, if you have a boy, he's got autism, I'm just being quite stereotypical. He might be really fixated on trains or something like
Dinosaurs.
That. Whereas girls might be fixated on horses. But actually for girls, it's quite normal because lots of girls like horses or bunnies or something like that. And with girls, because girls get quite fixated on things like boy bands or something.
Yeah.
So people don't pick it up as easily and they don't expect girls to get it just with like ADHD. So you most likely pick it up with boys because you expect boys to get it actually.
Well, that's interesting. No, that definitely is interesting.
Well, I wouldn't necessarily, those symptoms are vastly different. It's just you don't think girls will get it.
So it's really the recognition.
So you don't look out for it.
Yeah. It's the recognition of going, that isn't a normal obsession with that particular thing that they're obsessing about. No, that's interesting as well. I like that one. So another one. So this is probably something that Becky comes across quite a lot. she obviously is dealing with teenagers. And how can we support teenagers, particularly when they're taking medication, and help them try and dispel some of the worries that they have associated with taking that medication? Because you want them to comply with what you guys have given them, but what could a teacher do or a parent do to try and encourage them and get rid of those worries, really?
Yeah. So as we said with treatment, there's all these different programs and they're so varied. So, you know, these skills programs, a parent training program, educational, there's groups, a CBT, there's so many different things. And I think just making them realise they're normal, like in quoted brackets, like it's just a medication to help them. They're not abnormal. No. And just like if you get a scrape and you need an antibiotic, it's that kind of thing. That's how I like to always normalise it. And I think just making them comfortable. So maybe taking them outside the class and having a chat with them, not making them feel embarrassed and letting other, obviously, students know, and just normalising it. And one thing that really helps is actually making appointments with doctors after school instead of in school, because kids can be quite mean and be like, you know, that's the sick child and they're always missing school, what's going on? And it makes them feel more embarrassed and then they don't want to comply. And I think the most important thing is making them feel that actually they're normal, they just need a different kind of help, and that's fine. And I think you've just got to be patient with a child, and also in a class. I mean, I'm not a teacher, but from what I've heard is just doing subtle things that help them. So whether moving them in a different area of the class so they can pay attention better, sitting with a different individual, helping them a bit extra, they need it in lunchtime classes, taking that time and the patience. So I think that's the thing. It's just having that patience with a child. It can be, you know, I'm sure people get quite frustrated, especially as the parent, because in front of you, you think you're seeing a very naughty child, not, you know, listening to you, but it's not that. They're just struggling to pay attention. So just working around them and changing the way you interact with them. So it's just educating yourself as well. And there's lots of programs for parents and teachers to help them improve that.
I know that Becky, as part of her role, she has a big push on trying to help those particular kids because that is part of her role. But I mean, she's got one teenager that has issues maintaining concentration for an entire class. And there's a point where they've got to get up and do something, which obviously goes against the way that schools are run. You don't get out of your chair and wander around. But she's come up with this kind of idea of, could you just take this note to this teacher?
And they get up and they go off
and they give the note, and then the teacher's like, thank you very much, and has a bit of a conversation with them. And then they head back to class because they've then got up, they've got rid of that energy that they were kind of trying to hold back, because they don't necessarily want to be doing that behaviour either, because I don't know, if these kids are probably self-conscious. Isn't it
That's
cool?
excellent, Becky does that. So I was about to say, I met this boy, and because this boy, I forgot to mention that, he did that as well. His teacher got him to like run an errand or something sort of every class, and I think that's so excellent that Becky's doing that.
Yeah, just to get rid of that additional energy so that they can come back, because she's like, they come back, they sit down, they get on with their work again, which and the problem is, again, it's the education of the teachers as well, because I spoke to Becky and asked her how much they do about certain mental health issues in themselves, and they don't necessarily do a lot, but they obviously do additional courses and stuff. And so she's come up with all of these different techniques and stuff to try and get them to just be able to concentrate for the amount of time that they're asking for, because at the moment we are trying to do the one size fits all kind of way of teaching, isn't it? And some kids need to move, and it doesn't. Exactly. Some kids just need to move. In coming back to medication, oh, sorry, did you want to say something?
No, I was just going to add, I think that's really great, because I can imagine it's really difficult to be a teacher, actually, and especially when you've got such a large array of children and different facilities and to be aware of so much. I was just going to mention, because I have dyslexia and wasn't picked up for a while, and I really struggled in my classes, and it was only when I had a very supportive teacher that actually took the time out, and she worked differently with me. And it sounds like Becky's that kind of amazing teacher, actually.
She is,
that is so supportive, and I think that's great. I wish more teachers were like that, because you can really facilitate a child to be the best academically and in themselves, and I think that's really great. So I hope it's just about education again, and it's a difficult job, and just having the teachers willing to help as well.
Well, the other issue that Becky's facing is obviously with more government cuts coming in and class sizes increasing, and it's not easy in terms of you guys in healthcare or guys in school. It's just, it's getting more and more
one
tricky.
obstacle,
Yeah, exactly.
One more.
So I've got some more questions. So Becky has asked, how is it best to deal with the side effects of some of the medications that children might be prescribed? So in terms of the ADHD medication, what kind of side effects could the kids get? And how can you help them through those side effects?
Yeah, I mean, side effects is quite varied. And we'd always start on the very lowest dose. So the kids I saw, they don't actually have had any side effects. That might just be an optimistic caseload I had. But we start very little and we regularly see them. So, and they would usually be put in CBT as well. So they have extra support. I mean, it's with all kind of medications. They're so varied. So normally with any medication, you kind of get nausea. And you can get headache and your sleeping pattern's a bit ruined and appetite's also ruined. But with children, you've got to be a bit cautious also if they're not growing properly with these kind of medications, because you're giving stimulants. So you've got to just make sure that's okay. But generally, the ones I've seen have been okay. But if there was any side effects and the children are experiencing it, what I would say is you just make an appointment again with the psychiatrist, and either they lower the dose or they can change the medication or try it without. Yeah.
So I think the main one that she has experienced with kids is nausea.
Right, yeah.
So that's probably her biggest issue at the moment.
But sometimes also with nausea, it's also the timing. So some children take it at night time. So the nausea effect kind of goes when you wake up.
Yeah.
So it's just fiddling around really, like when it suits you.
So that might be something she could speak to the parents about, is looking at changing the times and things. That's a good idea.
Yeah, and definitely make an appointment with the doctor as well, just to discuss as well, I'd say.
Cool. Okay. So Becky's also asked, what other conditions or illnesses are often associated with ADHD, and if there are any?
So we spoke about that. So the comorbidity. So it can be linked with like conduct disorder, mood disorder, anxiety, oppositional, tics.
Cool. Yeah. Excellent. I completely forgot we talked about that. Another thing that Becky has faced is that she's had issues with getting some of her kids into CAMS for referrals and for issues with getting their medication checked and things.
Really?
Yeah, I don't know if that's just a sorry thing.
Okay.
And she was wondering if there is anything specifically that she could do to help those kids if they're having issues getting the help that they need.
Yeah, I'm surprised to hear that, actually. Yeah, I've never experienced that. Probably because I work in London. We have so many CAMS facilities. They're just potted around everywhere. Possibly in other districts and other situations, maybe the services, there's not so many. So it could be, I mean, there's not anything like trigger words you can say. If a child's really having, I'm surprised actually that's happening. I'm quite shocked about that.
Yeah.
If the child's already under CAMS, they should be actually regularly reviewing the patient. If not, GP is always the next port of call, because GP also has a bit of education about this, and sometimes they have a psychiatrist working with them, and also GP can fast track an appointment quite quickly. And sometimes it needs to be by doctor by doctor. If that's the case, I would always go straight to the GP, and the GP will then be the next port of call, basically, if you can't get hold of the CAMS officer. Some schools, but it sounds like Becky's doesn't have that, have actually a CAMS counsellor or CAMS therapist, and sometimes psychiatrists actually go there. So I've done a few school visits where I see the child.
Really? Oh, that's cool.
But I guess because I'm in London, so we have that facility. So with Becky, I would say if you can't get it directly, with the referral and they're not making it, I would go to the GP, because the GP will get it done.
Okay, brilliant. Okay, I shall pass that information on. So the one thing that I was interested in, because it's something that I've heard, so my sister, before it became ADHD and it was ADD, my sister was diagnosed with ADD, and everyone would just be like, nope, it's not a real condition. You've just got a naughty child on your hands. You need to discipline her more, and you need to try all these. You have to try the naughty step. And that didn't work. My sister was naughty step and a child with ADHD.
Nope.
Do you really think that's going to help? But she would get extremely, if anyone gave her chocolate, she would be literally bouncing off the ceiling. And there was one day that she was given a penguin, and you know how little penguins have in terms of chocolate. So it's like a chocolate biscuit and it's got the tiniest amount of chocolate on it. She literally ran from one corner of our lounge to the other corner for 4 hours straight and didn't stop. And I think she was about 6 or 7. Everyone would just be like, you've just got a naughty child, just discipline her more. And it's not a real condition. And what kind of thing would you say to help reduce that stigma associated with that it's just a naughty child?
I mean, that's something we said earlier. I mean, there's lots of people think like that, actually, and they think that's why that's associated with the Western culture. But we have said that there are actually other elements. You do have neurotransmitters, and there's theories about that, and head injury can increase your risk of ADHD. So there are physical factors on this, and genetic as well as physiologically. So it's not behavioural. It's not a child being naughty, actually. I think that can be a slight element of it. I won't disagree with that, because there can be elements of that, but it's not simply that. There's other factors going on medically as well. And behavioural treatment can help, but it's not just that, actually. It's multimodal. You've got to do other things as well. So I'm sorry, anyone listening, but it's not just a naughty child. You can get naughty children, but this isn't what ADHD is. It's actually, you are getting these, horrible impacted symptoms of inattention, hyperactivity, impulsive, and kids don't want that. They don't choose to be like that.
Exactly. If they chose to be like that, then they would probably choose something that was easier on them, because I'm sure they probably don't enjoy being constantly told off by everyone around them. And it's not pleasant for the child. They don't want to feel excluded and feel like that at school. Like, children like to fit in. Exactly. Well, I think, unless you've got anything else to add, that's all my questions.
I just have one tiny thing I just remembered. There's a lot of people think that certain dietary, so like additives, sugar, lead,
that's a good one.
Whatever.
Yeah.
There hasn't been anything found on that increases your risk of ADHD. So
that's interesting.
I wouldn't be concerned about that.
Oh,
There's
back in the day, everyone was like, don't give them E-numbers. Don't give them E-numbers. I'm like, you do just know that E-numbers are additives that have been approved by the European Union. That's all they are. It's like citric acid is an E-number. Everything's an E-number. That's just how they do it.
Yeah,
exactly. Don't give them sunset yellow, because they'll bounce off the ceiling. Anyway, so that was ADHD. If you have any questions or comments about ADHD, please let us know. If there's anything else that you are interested in and would love to have an episode on, again, let us know. Really would encourage you to get in contact with us, because we want to be able to give you the information that you're interested in. And if there's anything that we haven't covered and it isn't necessarily on our list, let us know. Just give us an email. We'll put it on the list and we'll talk about it. So in the meantime, it's okay to not be okay. And if you're not okay, talk. Thanks for listening to this episode of the Mental Health Book Club podcast. If you need additional help with your mental health, please contact the Samaritans on 116-123, which is a 24-hour helpline. And if you need additional information about mental health issues, please visit Mind at mind.org.uk. Our next book will be A Beginner's Guide to Being Mental, an A to Z from Anxiety to Zero Given by Natasha Devon, MBE. Our next episode will be an interview with Natasha Devon, MBE. If you'd like to find out more about the MHBC podcast, please visit our website, mentalhealthbookclub.com. We really hope that you enjoy this podcast, and we would like to hear what you think. Please head over to Twitter and follow us at MHBC_podcast, or head over to Facebook and follow our Facebook page, which is Mental Health Book Club. If you would like to show your support further, please share us with your family and friends, and leave us a 5-star review wherever you get your podcasts. We are now on Patreon. Please head over to patreon.com/MHBC to donate as little as $2 a month to the Mental Health Book Club podcast. As a result of your donation, you will get early access to some of our episodes, you will get specific episodes that are only for patrons, and you'll be eligible to be entered into free prize draws.